Welcome to Frank Talk. I'm Albert Dadon, your host today. I have from Tel Aviv Professor Eyal Leshem. Welcome, Professor.
Thank you. It's a pleasure to be here.
And if you don't mind, I call you Eyal.
That's perfect.
Because we are as informal as you guys are in Australia. Eyal, is it possible for you to introduce yourself, give us a shorthand about your long and distinguished career, please?
So I am an associate clinical professor for internal medicine and infectious disease in Tel Aviv University, an infectious disease specialist with a diploma in tropical medicine and hygiene from Glasgow University. I have served a 3-year tenure training and tenure at the American US CDC in Atlanta, doing a training called Epidemic Intelligence Service, where I trained in outbreak investigation and vaccine preventable disease, deployment of vaccines in middle and low income countries. And I also practice internal medicine and infectious disease at the Sheba Medical Center in Tel HaShomer as the director of the Center for Travel and Tropical Medicine.
And is this where I'm finding you, in Tel HaShomer?
Absolutely. That's where I've been the last half a year. Haven't left Israel since, I think, late 2019.
So Eyal, what does your day-to-day look like?
So my main tasks of the day are I'm in charge of a couple of inpatient services where I provide infectious disease consult. At the last few months, it's been oncology and ENT. I see and consult returning travelers when they come back with a febrile illness or with suspected tropical illnesses. And this we've been doing for a long time. We have the largest center in Israel for travel and tropical medicine, and we see several hundreds of return travelers a year. This activity is obviously much reduced now due to Corona. We don't see a lot of travelers, but we still have a lot of Israelis deployed for work and for other purposes around the world, and we do consult them every once in a while. I work at the Sheba Hospital Management, giving oversight to some COVID activities and projects, and with the infectious disease unit doing some other projects.
So obviously you are not, it's impossible for you not to be involved in the COVID situation in Israel. Were you surprised when the pandemic started? Is it something that you expected?
I must say, among public health professionals, this outbreak was anything but a surprise. So if you look back, the world has been preparing for a pandemic of a respiratory virus for years, more than 10 years now, preparing blueprints. In many of them, the name of the virus would have been pandemic influenza, but the impact would have been very similar to COVID with one difference. In pandemic flu, we tended to think that we will have a vaccine at hand quite fast, whereas for COVID or other diseases, we knew that safe and effective vaccine development and deployment may take a little bit longer. However, the World Health Organization has prepared blueprints for a disease they named Disease X, and this happened 2 or 3 years ago, for exactly the same scenario we are experiencing right now. So this human-animal contact, we like calling in public health One Health approach, which means if there are diseases in animals, these diseases may spill over to humans. And if one of these viruses mutates and becomes infective between person to person and not just jumps from an animal to a person, this may cause or may result in outbreak or a pandemic. So we've been preparing for such a pandemic for many years now. We've had the tools and the blueprints in hand, and we also had a faint guess that this may rise from China, because the last two, or one of the last two threats did come from China. This was SARS. Other similar threats were MERS, which stemmed from the Arabian subpeninsula, Ebola, which was very different, but also resulted a global public health response in many aspects and a vaccine development. And of course, the bird flu, which is detected in many places, but is similar in our concern. So here's a virus that attacks animals, birds, very lethal in humans that get infected, but at present does not transmit very well between one person to another person. So you may get infected from a bird flu, from close contact with a sick bird, but you will not infect other persons. If this virus mutates, then we may be in trouble.
So in terms of this current pandemic, I believe it started around November in China. Do you think, what's your theory as to why the Chinese took so long to actually alert the world?
Well, you know, not being on the ground, it's very difficult to really state as a fact that the Chinese purposely hid the outbreak. This could be simple lack of understanding that an outbreak is occurring. It could be that the Chinese actually went ahead and informed the world of a concern regarding a virus that was detected, because if you remember the reports from end of December, the numbers of patients were not very high, and they were able to at least consider a point source outbreak from that wet food market in Wuhan. And the sequence of the virus was very rapidly reported. So at the beginning, from the outside, it seemed like the Chinese government was collaborating and reporting as much as they could. Now, there are other reports suspecting maybe transmission occurred earlier, but really, until we sit on the ground and have the actual facts, I find it difficult to blame the Chinese in hiding.
So you heard, of course, the various theories, one of them by a professor in France whose name escapes me, but he had a Nobel Prize of Medicine that said that this pandemic, this virus was man-made. What do you say to that theory? What do you say about that? In particular, in the laboratory, in the Wuhan laboratory, near the wet market. I'm sure you're familiar with that theory.
Yeah, I will say three things. The most important, it doesn't matter where it came from. It matters that we have now a public health problem, and the tools to deal with it do not change whether it is man-made or not. The second important thing is, I am a disclaimer, I'm not an expert virologist, or this is a specific profession within the medical profession. But from most virologists I speak with, including very senior virologists from the National Institute of Health and from the CDC, majority of them don't think this was a man-made virus. To the contrary, looking at the genetic composition and the way the virus evolved, most of them think this is a natural One Health event, which means this is a virus that was transmitting between bats, animals, and people, like the SARS did, and not man-made by anyone. And that's what most virologists think. Now, again, the truth may never be found out, but this is not a typical biologic weapon incident such as the world has experienced in the past, where viruses or bacteria were leaked from laboratories. This incident is very different, both the pathogen and the way the pandemic evolved.
So it's been now 8 months that the world is looking at this virus. Do you think it has evolved? I give you an example that maybe is a little bit alarming, is that earlier on set, we were thinking that kids were totally immune from this virus, we're now finding that kids are no longer immune from it. There are some people reporting having trouble, neurological trouble 3 months or a bit less after they were cured totally from the disease. Do you think that this virus is evolving at present?
No, to the contrary. Most pathogens that are familiar to us, the infectious disease specialists, do not change rapidly. They may change in a way like the influenza changes, where if you were infected, the virus changes and then it may cause a subsequent infection because the immune generating parts, the antigens change. But the pathogen itself, the way it causes disease in humans, does not substantially change. Once you have a functional pathogen like influenza, like measles, like polio, along the time, sometimes for hundreds and thousands of years, the pathogen causes exactly the same disease. Exactly the same disease. So the virus does not change in the disease it causes. It sometimes changes in the immunogenicity. So you were infected, because it changed, you are no longer immune. And sometimes it changes in the transmissibility, but the virulence, the disease caused by a virus to a person, does not change substantially, and this virus is not different. What is changing is our knowledge, our accumulating knowledge of this disease. Because as time passes and the disease is introduced in thousands and hundreds of thousands of cases, doctors observe various phenomena. So initially, we saw the simple flu-like illness with a high rate of severe pulmonary disease. But as we were hospitalizing and collecting data on more and more patients, we are seeing more and more phenomena, as is common in every common disease. So every common disease has a common presentation and has rare manifestations. And we are now describing these rare manifestations that are happening in a very small proportion, like the long-term neurologic phenomena, or the long-term pulmonary phenomena, or the multi-system inflammatory syndrome in children, which is not common, but happens. So this is typical of learning new things about the disease. I don't think the virus substantially changed.
Okay, so talking about the toolbox that you have, is that also changing? Are there new remedies that are, I'm sure there's lots of research happening in that domain, of course, but can you describe the most efficient ones, please? And the ones that, in particularly, the ones used in Israel at present?
So there are 3 toolboxes for an infectious disease. The first is treatment, the second is vaccine or immunization, and the third is public health measures to prevent transmission. The most important are the preventive ones, the public health tools and the vaccine, whereas the less important from a public health perspective, from a statewide perspective, is the treatment tools. But the treatments are very simple to describe. We currently have only 2 effective, proven treatments to this virus. And these are the very old, tried and tested steroid, dexamethasone, that provides some improvement in the prognosis of moderate to severe patients. And there are data that are being released, initially a British study, now a follow-up. We're talking about a reduction in several % of the proportion of people that deteriorate from moderate to severe to death. The other tool is an antiviral called remdesivir that was shown in several studies to reduce the duration of symptoms, and there is good, at least it is quite reasonable to hypothesize that also prognosis is better in patients that are treated with remdesivir. Other than these 2 drugs, we did learn how to better manage these patients, give them supportive treatment. So when initially we used to go very rapidly to mechanical ventilation because we thought this is going to protect the lungs, we actually learned that it's better to try and prevent mechanical ventilation by use of a very high flow supplemental oxygen to maintain oxygenation. We learned how to use ECMO. We also learned what patients have a very poor prognosis, and we can make a decision not to move forward with very invasive, painful treatments if the prognosis from the beginning is very poor. This is regarding the treatment, and it's quite straightforward.
So regarding Remdesivir, I understand that's the Gilead pharmaceutical product. The studies are showing that there is quite a high level of toxicity in that. So the remedy might be worse than the disease itself, don't you think?
No. In medicine, just exactly like in life, there are no free meals. So when there are no medicine without adverse events. And Remdesivir has adverse events, but from both the clinical studies and our own experience here at Sheba Medical Center, which is the center that treated most patients in Israel during the first wave, we know that patients that were on Remdesivir had a better prognosis, a shorter duration of symptoms. Even if they suffered some adverse events, their prognosis from severe COVID was much better. And so we know that sometimes antibiotics have adverse events, and sometimes cardiac drugs may have adverse events, but we still give them to save the patient from their main problem, which is at present the COVID.
So have you heard of hydroxychloroquine?
I'm well, as a tropical medicine specialist, I'm well familiar with this medicine.
So you've heard about Professor Raoul in the south of France, in Marseille. He has published a case study of 4,000 patients in his hospital in Marseille. And he's reporting, I think, some of the best results in the world using hydroxychloroquine and azithromycin. I'm surprised you haven't used those two in Israel, given that you've got Teva supplying the world with hydroxychloroquine.
Yeah, unfortunately, I'm well familiar with Professor Raoul's work, and unfortunately, they are not in par with what we today consider grade A evidence for treatment efficacy and safety. The interpretation is Professor Raoul presented observational data as contrary to randomized controlled trials that are now the gold standard to prove treatment effectiveness and safety. Now we know that both azithromycin and hydroxychloroquine are drugs with adverse events that are well reported in many other settings. There were some evidence to suggest that perhaps hydroxychloroquine reduces viral secretion, but when the World Health Organization started a randomized control trial about hydroxychloroquine, this was discontinued because of higher rates of adverse events and no prognosis benefit from the hydroxychloroquine arm. So we think Professor Raoul was trying to do good, but unfortunately the evidence presented by his team were not on the level that allows use of hydroxychloroquine. Many Israeli doctors unfortunately did use hydroxychloroquine at the onset of the disease, contrary to the recommendation of Professor Anthony Fauci from the NIH that said, please do not use drugs outside the context of a randomized control trial, because we will never know if the drugs are effective or not. So many doctors did use this, and it was a mistake, and I can explain why. When you have a disease like COVID, that 90 or 95% of patients infected with COVID recover, even if you don't give them any drug. Then if you simply give the drug hydroxychloroquine and you see a patient recover, you may be convinced to think that it was the drug that caused the recovery. For this, you need a randomized control trial. Half of the patients will receive the trial drug, for example, hydroxychloroquine, and half will receive placebo. neither you, the doctor, nor the patient will know what the patient is getting, hydroxychloroquine or placebo. And when you measure the results, you can actually prove that it was hydroxychloroquine that caused recovery and not a natural course of disease. This is the current gold standard for collecting evidence in the medical profession, and this, unfortunately, was not done in Marseille.
So a couple of things on this, if you don't mind, Eyal. The first one is about the WHO interrupting the randomized survey or study on hydroxychloroquine. That was due to a publication called The Lancet. They published quite a damning report on hydroxychloroquine, but then very quickly after that, The Lancet has withdrawn that study because it was full of errors. And however, WHO, I'm not sure they resumed their study about hydroxychloroquine after that. About what you're saying on Professor Eyal in Marseille, I totally agree with you that what happened when he first published his first few cases, but since then he has used the randomized study, as I mentioned to you, the 4,000 cases that was a study that was published, but there's been many others. The latest one that I'm aware of comes from Nevada in the United States, where it has been proven that the hydroxychloroquine reduces the number of days that someone carries the virus quite considerably. The other thing that I'm very surprised about the medical profession, I mean, until this pandemic, I used to think that the medical profession was a science. And now I'm finding out that it's an art instead of a science. Maybe it's at a crossroad of many sciences. However, the way that doctors interpret this or that, to me, it sounds more like an artistic license, because I'm unable to find a group of professors that will agree with each other on anything. What you're saying, for instance, I've heard it before, and I've heard also the opposite of what you're saying. So it's quite disconcerting, which is why I wanted to have this discussion with you, because I'd like to understand how do you make, when you are a layman, when you are the public, how do you make sense of all of this? When what is toxic? For instance, you say remdesivir, that's very toxic. It's much more toxic than hydroxychloroquine. But yet hydroxychloroquine is also toxic at some level. As you said, every medicine is toxic. But then it is problematic for hydroxychloroquine, but not problematic for anything else. The other thing that what you said is that you're talking about randomized double-blind, but until very recently, I mean, take penicillin, for instance, there was no such standard. There's so many examples in the history of medicine. Polio is another example. When the vaccine for polio was found out that it worked, it was just totally given to the whole population. So there is a lot of contradictions in your profession, sometimes illogical arguments that I'm counting, that I'm coming across. Is there a systemic failure of logic at present in the medical profession, or is this simply the way it goes? It's the best argument wins. We have discussions until we agree, type of thing. What is the scenario in your opinion?
That is an excellent question. The bottom line is, for many years, we practiced, for centuries, doctors practiced medicine with logic and personal experience. So hundreds of years ago, they thought that if you bloodlet someone, they will feel better. And bloodletting was a very common medical practice. Several decades ago, it was cardiologists observed people with a heart attack and noticed that right after the most common cause of death after a heart attack is an arrhythmia. The heart stops pounding regularly and becomes very irregular, and it kills patients. So it is only logical then to give them a drug that is antiarrhythmic to prevent this death, until they decided to conduct a randomized control trial. Half of the patients after a myocardial attack would get an MI, would get antiarrhythmic, and the other half would get standard treatment without antiarrhythmic. And lo and behold, guess what happened? It was not logic that prevailed. They actually found out that the patients that got the antiarrhythmics had a higher mortality rate than those that got only aspirin and some beta blockers. What I'm trying to get at is that while medical hypothesis has to be based on logic, medical practice has to be based on evidence, always on evidence. So if something makes sense, like if you give a drug and there is less virus secreted, it only makes sense that it makes the patient better. As long as this is not proven in a randomized control trial, you don't have good evidence to practice. You may actually be killing the patient with the drug you think you are helping him. So medicine is a very logical profession, but the practice of medicine today must only be based on evidence, and the top grade of evidence remain randomized controlled trials. This is the way we practice medicine today. And it is not logical for a layman reading and saying, well, it makes sense that an antiarrhythmic will save someone. Why aren't you giving this to patients? Because we have to collect evidence. And our first law in medicine, and this was taught us by our ancestors, is primum non nocere. First of all, don't do any harm. Before you save the patient, don't harm them. Don't give them a harmful drug or a harmful treatment or surgery. So what we do when we test a new therapy, we first do a safety testing, make sure the drug is safe. Then we do an active efficacy testing through a randomized control trial. And after we have these hard evidence that the drug is safe and effective, only then will we recommend. And any drug tested or tried in other circumstances may backfire. And this is in a nutshell, how we aspire to practice medicine today. Has limitations because many diseases and many drugs were not tested in a standard randomized control trial. And in these cases, we will revert to our logic and experience.
So I understand about randomized controlled trials, but when it comes to a pandemic and when you have a situation where a doctor is confronted with a life or death situation, is it fair enough for a doctor to actually use his discretion, or do you think he still has to go, like for instance, if in the case of Raoul, what he's saying is that he has discovered very early in the piece that this hydroxychloroquine was reducing the viral loads in patients, and then he said that his Hippocratic oath didn't permit him to then provide a placebo to someone who was going to be harmed, given the fact that he knew that the hydroxychloroquine was going to be bringing down the viral load in the patient. So there are those cases, and then there is also in any field of human beings there are commercial interests, and I understand that hydroxychloroquine doesn't cost much at all, like it's 5 cents or less per dose. When you're talking about the Remdesivir, you're talking about a couple of $100 per shot. And also, I understand that Remdesivir was a recycle of a medicine that was going to be manufactured for the Ebola virus, and it didn't work for the Ebola virus. And then suddenly it's being recycled for this coronavirus. without any great success from all the data I'm seeing now. If Israel has different data, that would be absolutely extraordinary. And I would love to see that, because that would enlighten me for sure. But in any case, there are commercial interests. And in your profession in particular, where researchers such as maybe yourselves, I don't know, are subject to grants by governments and so on, it seems to me that there is the general way of thinking, and the randomized, standardized way of approaching things ensures that those grants are coming for those who are recycling old medicine, and God knows if there are old medicine that are out of patent, that it's very difficult for large companies, pharmaceutical companies and so on, to make any money from. Then you might also understand why there is this propensity to look at what's new, abandon what's been proven in the past, but it doesn't make any sense commercially to pursue anymore. You don't think that that plays a role in the choice of what the toolbox says?
Let's start with a disclaimer, because we didn't have one in the beginning. I have no conflict of interest to declare, and I'm not on a payroll or consulting or hold any equity in any drug firm, neither one that's involved with remdesivir nor any other drug or patent at the moment. So I'm speaking strictly as a government worker in Israel and as a public health professional. The purpose of randomized controlled trials that are traditionally not conducted by the pharma that holds the patent, but by a clinical randomized controlled trial, separate independent firm. The purpose of this separation is to make sure that the drug is tested in objective way. And the regulator, the objective of the regulator, may be it the European or the American FDA, is to make sure that drugs are tested in an ethical and in a valid scientific way before they are approved with an indication. Now, the government objective, or specifically the Ministry of Health, objective is to provide the best treatment and the best healthcare to citizens. So it is the government's job, or for a global purpose, the World Health Organization job, to make sure that drugs that do not have a patent and there is no commercial interest in development and trial, to finance and trial the randomized controlled trials for testing drugs like hydroxychloroquine or azithromycin. So up to here is the way we present the field. This does not change one bit the basic assumption that if you want to give a treatment to a patient, it has to be evidence-based. It cannot be based on reason, and it cannot be based on your anxiety or fear to a patient, because you may end up breaching the first law of medicine, we see, which is primum non nocere. So if you give a drug that was not proven to a patient that isn't severe, I can understand the psychological appeal of doing something rather than sitting back and looking at the patient suffering. You want to do something, but you may end up harming the patient. The ethical thing is to conduct yourself a randomized controlled trial. If the drug doesn't cost much, like hydroxychloroquine, you should do what we did in Sheba Medical Center, which is a randomized controlled trial of hydroxychloroquine versus a placebo versus chemostat, another drug. And we were in the process of collecting this data, where we had firm evidence of efficacy of remdesivir and had to add it to the protocol. Mm-hmm. What I'm aiming at is, when you collect data, when you have enough patients, you have to conduct good trials. And if drug companies want to do it, it is the government's job to do these trials. And there are several government-funded medical trials of medicine that don't have patents. This classically happened in the US, where the NIH tried disotiazide, which is an old patentless antihypertensive against new patented drugs, and showed that it was as effective, and it entered the guidelines for hypertension treatment, even though there was no company behind it.
So yeah, thank you for your disclaimer. I give you also a disclaimer. I have absolutely no interest with hydroxychloroquine or any other drug. I'm just curious to understand what is the process, but maybe enough of that. And let me go into another subject, which I think is much more interesting, and that's the one of vaccines. Where are we at with vaccines? I know that there were in the early onset about 70 companies trying to find a vaccine. I know that in Israel you have 1 or 2 companies that were already fairly advanced. Is there any chance that this is going to come to fruition? What are the chances of this to get there?
So the guiding principles of vaccine development are even more strict than testing drug on patients, because vaccine, bear in mind, we give to healthy persons. So we want to make sure at first, always make sure that their safety profile is excellent. If you want to give a vaccine to your whole population, your first objective is to make sure they are safe. All vaccines in current use entered the last 20 or 30 years, except one, which was pulled back from the market in 1999. All of them are very safe and were tested on tens of thousands of patients, randomized before entered, and on millions of patients after they were entered. So that's our first guiding principle. The second is test efficacy, and these are again huge clinical trials. At least 3 vaccines now, the Oxford vaccine, the Moderna NIH vaccine, and the Sinovac, the Chinese vaccine. These 3 vaccines have entered the clinical trials stage, the large clinical trials of tens of thousands of patients across continents, and hopefully within weeks to months, we will start seeing publications on their efficacy. And once we see efficacy data, we will be at a much better place to understand if we have at least one vaccine candidate. Now, from looking at the field of vaccine development, we know that there are actually more than 140 vaccine candidates in different stages. Some of them are just a molecule. Some of them are as advanced as the Oxford and the NIH Moderna vaccine in clinical trial. So it is fair enough to guess that within several months we will have at least one, if not more, vaccines that show some level of efficacy, at least for 1 or 2 years. Now, what will happen then is each vaccine, I think, will try and refine the population that it is indicated for. So perhaps one vaccine will show higher effectiveness, efficacy in older population, or a longer immunity, or a better adverse event profile, less fever and headache for people that get it, whereas another vaccine will say we're better in healthcare or in kids, and so on and so forth. So each vaccine company will try and refine the indication or the label and go for that market. And the big question is which vaccine will show long-lasting immunity and a high level of efficacy, which means perhaps not complete prevention of infection, but rather a substantial reduction in hospitalization, mechanical ventilation, and mortality rate.
So, in your opinion, how far away are we from a vaccine?
This is nothing but an educated guess. My guess is that within a few months, we will see at least 1 or 2 of these vaccine candidates publish randomized clinical trial data showing some level of efficacy in reduction of severe disease, hospitalization, mechanical ventilation, or mortality. And once one of these, even if it's a 20% reduction, if it's statistically significant, if you're told you will get a shot that has very few adverse events and your risk of dying of COVID drops in 20%, that will be a good result, and this vaccine will go into production until we have a better one. Now, the NIH has specifically asked to see better efficacy results. They wanted to see a higher reduction in severe disease and mortality, but we will see the published results, and then the decision will have to be taken. Bear in mind that each of these vaccines, once shown to be clinically effective, it will still take a few months to ramp up production. We are talking about the global population of 9 billion. Most of these vaccines have a protocol of at least 2 shots. We're talking about producing nearly 20 billion shots, producing, disseminating, providing to the population. It's a huge logistic effort. These have to be manufactured in good manufacturing practice facilities, which take time to build and develop. Some of these companies are doing this on parallel. They develop, they try clinical trials, and they also already plan to ramp up production.
So yeah, how does it work when you go on the 3rd stage of this trial? Those who receive the shot, how do you actually know that they are immune? Are they getting exposed to the coronavirus to see if they can resist? What is the
No. The key is to conduct the clinical trial where the disease is endemic, where there is transmission, so that some of these that are vaccinated are exposed. You monitor these patients that were vaccinated. You ask them to call you if they develop any symptoms, and in some of these protocols, you test them periodically for serology or PCR to try and identify if they got infected. And the sample size calculation, trying to calculate how many persons you need for this trial, it takes into account the incidence of infection. So if there's an incidence of 1 or 2% of the population gets infected every month, and you have 30,000 people, you will get at least several hundreds of infections within several months of trial. And then half of them are vaccinated, half got the placebo. You can actually compare the proportion of severe patients among those vaccinated with the real vaccine to those vaccinated with placebo.
Very well. Now, the case in Israel, how are you guys doing there? Not long ago, I haven't checked for the last week or so, but you were getting like 1,200 new cases a day. Is the curve going the other way now, or is it still ramping up?
Well, what happens in Israel is an interesting situation. We did very well on the first wave. March and April, we got to a peak of 700 cases a day, went into complete lockdown curfew, and the epidemic curve dropped, so that during several days in May of 2020, we had a nadir of 5 cases every day, 5 in the whole country. However, the virus did not disappear, and as the economy, schools, workplaces reopened, we started seeing an increase in the virus. What we have today are regulations that mandate face mask use, ban mass events over 20 persons, and several other, and schools are obviously on vacation, so we don't have schools, which are major drivers of respiratory virus transmission. And we have flattened the curve to a point where we have somewhere between 1,500 to 2,000 cases every day. A little bit lower, but it's been like that for 3 weeks. And the reason for the flattening but no decline is, while we stopped allowing weddings and mass gatherings, the main cause of the increase was infections in weddings and infections in schools. So schools were closed early July. Weddings, mass gatherings, and pubs and dancing clubs and shows were all banned in about a month and a half ago. And since then, the curve flattened. We are unable to further reduce the number of infections because we keep doing everything else as usual. So people go to the beach, people go shopping, visit shops, go to restaurants. So as long as there's person-to-person contact, there will continue to be infections at the same level until there is some change.
So that's
the problem is...
sorry to cut you, but I saw some big demonstrations in Israel about people going against confinement as early as about 10 days ago. So what you're saying is that now the country is deconfined again.
Yeah, demonstrations or the right to demonstrate is a basic democratic right. And when the government weighed the damage from not allowing people to demonstrate outside in the open from the benefit in terms of public health, it was decided that demonstrations are going to be allowed. And it attests to the democratic nature of Israel, where they say we are able to ban weddings and rock shows and dancing parties, but we will not ban demonstrations because then some people may think that the government is using the disease to infringe on democratic rights. So demonstrations are allowed. Demonstrators go, most of them will go with masks, and you know, you have to consider what the price you are paying. Of course, the easiest to reduce infections will be to tell everyone, go into your home, lock in the door from the inside and don't come to any contact, so to speak, be in jail. We will not have any civil rights, but the disease will be gone. So there has to be some balancing.
Very good, because here in Victoria, where I'm calling you from, that's our case. We are in what is called stage 4. We are in lockdown. We're not allowed out just 1 hour a day to go for a walk, or one family member only is allowed to go shopping. And we have a curfew that is from 8 p.m. until 5 a.m. But what you are telling me is that the Bibi Netanyahu government has actually relaxed what were considered to be quite severe laws in terms of the confinement. That is the case, right?
What happened is, since early May, nearly all regulations of social distancing were discontinued, except just a handful, which are the mandatory mask use and the ban for mass gatherings of over 20 persons. And something has to be said for this decision. While the disease has a major healthcare cost in lives lost to people that die and in the burden to the healthcare, the curfew and the lockdown has a huge economic cost. Now, nowadays, economy and healthcare are not closely connected. So if there is a cost of several billions of dollars for every week of lockdown, these billions of dollars lost by the economy mean that in 5 or 10 years, there will not be enough money to buy more hospital beds, more doctor and nurses positions, to pay for new drugs. So you have to balance the damage to the economy and the benefit to healthcare from curfew. And this balance is not easy because it actually puts a price on a person's life and say, you know, if every person's life is $10 million, then we can't afford it.
You seem to be having a very rational view on policy, which is the way it should be. Tell me, Eyal, what about the Palestinian territories? Do you keep an eye on them? What's happening there in terms of this COVID?
Well, initially they did very well in keeping the COVID-19 infections at bay. Unfortunately, over the last few weeks, there was a higher rate of infection. Obviously, the medical system in the Palestinian Authority has a lower capacity for treating severe patients. At Sheba Medical Center, we've provided some assistance, some training and some assistance to our colleagues from the Palestinian Authority. Of course, we've always been involved in treating complicated cases. Unfortunately, we are unable to admit COVID patients because we are ourselves, most hospitals in Israel are at full capacity in treating severe COVID patients at present. Israel has traditionally, I mean, the medical profession of Israel is, as everywhere else, is a humanitarian profession. And, you know, in French, you say that the doctors should not have doctors, or the famous organization, Médecins Sans Frontières. So I think we as doctors in Israel feel obligated to help anyone in sickness or in need, whether or not they are they belong to an enemy country or to a friendly country. A child in suffering or an innocent person in suffering is a person in need, and you mentioned the Hippocratic Oath. The Hippocratic Oath mandates help to anyone in need, whether or not they belong to enemy countries. And I think that is our view in the medical profession, and hopeful, and also in the political levels.
Eyal, I want to thank you for your very generous contribution. You've been very generous with your time. I just have one wish, if I may express it. I'd like very much you to advise our Prime Minister, and in particular our Premier of Victoria, to explain to him the rationale of deconfinement and the skill of taking risks. I want to thank you.
It's been my pleasure to speak with you, and I wish you all down there a healthy rest of the months, and hopefully things get better rapidly.
Thank you for watching Frank Talk on YouTube. Please leave us a comment and don't forget to hit the subscribe button.